Good morning, everyone. You all know me by now. This is Paul Hein. Today we're going to be talking about arthrocentesis. So, quick overview. Click where? Oh, there we go. So, quick overview. We're going to talk about why we do arthrocentesis. We're going to talk about the debates about using ultrasound pro and against. We're going to talk about a few tips about probe selection, about doing the procedure, some common pitfalls, and show you some cool videos, of course, because it's an ultrasound lecture. And we'll go through the relevant anatomy from head to toe. So why are we tapping joints in the first place? And why are we using ultrasound to do it? We were trying to confirm the presence of an effusion, which back before you had an ultrasound, you could do blindly if you had anything under differential other than effusion. And it's the only way to really know. If you're trying to sample something for lab analysis, you obviously need a sample, but also if you can get a larger volume aspiration, this is better both for any lab tests you need to do in case you have a small effusion and you are trying to split 1 cc between 5 tubes, or if you're trying to actually have benefit for the patient, since larger volumes tend to make patients feel somewhat better depending on the cause of the inflammatory joint or other cause of the effusion of the joint. And finally, knowing that you're in the right place is very important. If you're trying to inject medication, whether you're using lidocaine, ideally without epinephrine to avoid damage to cartilage, or if you're trying to inject Kenalog or some other steroid for anti-inflammatory purposes. This is up for debate and varies pretty widely in practice, but if that's your thing, you'll obviously want to be injecting to the right space and not the wrong one. So these are all things that we need to think about when we're thinking about using ultrasound in a joint tap. We have some controversies in it though. Recently in 2020, there was a study between, it wasn't a study, it was a debate between 2 groups of doctors for and against for using ultrasound in routine arthrocentesis. In favor was Gottlieb et al., citing an increased success rate, decreased pain scores rated by patients, decreased complication rates, and is there a real downside for ED residents who have ultrasounds in hand and have the training to use it? Against it says that most studies are not ED based, and that's true. A lot of the data is actually coming from clinics, whether it's rheumatology, orthopedics, or otherwise. Some even from ORs or inpatient settings. It could take additional time. It does take additional training. If that person doesn't have the training to use it, then that extra training is also extra time and extra expense, and the expense of the ultrasound machine itself. But as you pick apart the evidence that each one of these people cite, the evidence really goes more towards using ultrasound for anything harder than the simplest of knees. Even for knee taps, the success rate is markedly higher. This has been shown in multiple studies, but this is also true for injections. The hips can be pretty hard to hit. Orthopedics often doesn't like to go for an arthrocentesis of the hip. They would rather have IR do it. This might vary by institution, but this is pretty common here. If you're trying to get an injection into the hip, your success rate depending if you're in the right study, your success rate might be close to 100%, versus landmark-based tends to be lower. It depends on the joint, but was usually hovering around 70 to 80%, depending on the study you look. And then as far as other markers, not just the success rate of getting into the pocket or getting fluid, different studies have shown that you're able to reduce the amount of pain that patients experience during the procedure. You can also get more fluid aspirated out of the joint itself, and this is what people believe to be leading to improved pain scores at 2 weeks. Other than the preventing an extra puncture with a needle, there's one study that I didn't cite which talks about how the average number of punctures was reduced from 2 to 1 when using ultrasound compared to landmark-based lung. The savings are small, but they're supposedly saves $228 per provider per year. Another possible complaint you could have against ultrasound arthro is that it could take a longer amount of time. There was one study done at NYU Hospital for Joint Diseases of shoulder injections. The success rate was higher, which is unsurprising. The time was only longer by just about 2 minutes. Granted, these people had the ultrasound ready. They didn't have to go fish it from the other side of the pod, clean it off, restock the gel, and realize it was uncharged the whole time. So that all factors in, but it's worth noting if your ultrasound is there and ready, your time is slower, and with the rest of the complications, it might be worth it. As far as like looking at the most joints in one place, this study was only 32 patients in each group. You can see here, if you're looking at the shoulder, elbow, and wrist, these remember are not joints that we do taps of every single day. You can see the success rate is in parentheses and the number of attempts is outside. So the success rate for the shoulder, elbow, and wrist was less than 50% when doing blind, and the ankle was only successful 1 out of 5 times. Meanwhile, when you get, and you see the success rate for ultrasound guided is higher, and especially with these small joints, which you're very unlikely to even attempt completely blindly, unless you have a lot of practice, and that's a hard thing to get. For your probe selection, this is just something to think about, because we often by default use a linear probe for just about anything. But just remember that you can use your abdominal probe as well for the shoulder or for the hip in larger patients. If you can get away with a linear, you're going to have better resolution, and it might be better to go with that if you have a choice between the two. The final probe type is the pediatric linear probe, which, as you'll see in a couple of the techniques that we go over, is very helpful to have just that much more space, because for some joints your exposure is so minimal that you really need all of the room you can get. As far as the general rules of ultrasound taps, anything can be anything, meaning that you can look at a certain structure, and if you look at it from the wrong angle, it can look like an effusion. So it's really important to visualize and compress everything in 2 dimensions, both longitudinally and transversely. You always want to compare to the contralateral side, because you want to know, does this patient have, people can have a little bit of physiologic fluid in a joint space, and they can also have cartilage and other anatomical variants. You don't want to stake your bet using only one side when you freely have the other to compare to. Sweep the entire structure, sweep it in both planes every single time. Also, a quick shout out, please use if you have a central line mode on your ultrasound machine, which we all should, that is more in the center than M mode. M mode could move, and central line will instead be bound for right in the middle. There's a couple of pitfalls of using ultrasound, and they're just things to look out for. There's this wonderful SAT word, anisotropy, and just means not, and isotropy is just means uniform in all directions. So ultrasound is not uniform in all directions, it's anisotropic, which means that if you shine at a slight angle, you're going to not be able to see your object, because if your ultrasound rays bounce off at an oblique angle, it's kind of like a stealth jet where the rays don't bounce back at the probe. The probe is never going to pick those rays up, and you're never going to see your object. This is kind of like if you're doing an ultrasound IV and you're angling your needle incredibly steeply compared to the probe. There's a certain critical angle at which, if you guys remember your diffraction from physics, from angles of light bouncing off of water, there's certain angles at which point your rays are just going to bounce off into oblivion. So there's a video. Here's an image of what looks like it might be an effusion, and it's dark and it's there, and it's sort of a slightly rounded pocket. Maybe that's it. But if you move just if you move just a little bit medially, this is actually the ligament just above the patella. Which means that you're about to just stab into a tendon or a ligament. So anything, if you look at any structure that has a rounded edge and the edges and the sound waves bounce off the wrong direction, this is your punishment for not sweeping all the way, is going to be torturing the patient a little bit and being unsuccessful. Cartilage is another potential fake out, which it can be a dark appearance on your ultrasound, which looks a little bit like fluid. But if you note here, on the left side, you have the cartilage that's following the bone pretty closely. And fluid usually doesn't follow, like if it's forming in a single pocket, if you have enough fluid to create an effusion, it might push against the like linear dimensions and try, like all fluid under pressure, try to form a sphere. So it should have more rounded edges. And this is a really valuable time to compare bilaterally. And finally, there is this thing called synovial hypertrophy. If you look at the image on the right, you can see all these layers on the bottom. And if you look at the synovial space and you see the effusion, if you look at the bottom of it, you can see some small hypoechoic regions. So there's tiny little pockets of fluid in here, but this person just has, if you had just seen one of those fluid pockets, you might have thought that there was an effusion to tap or that there's an abnormal fluid. When really this person, they do have an abnormal synovium. And if you see pockets like this and you think that there might be something abnormal, if you throw color flow onto it, you can see blood flow, because synovial hypertrophy can result in growth of blood vessels. So you can see them actually flowing through what actually could look like just a dark space or a dark space that you think could be a little bit cloudy. So these will actually not compress very well. And that's just another thing to look for. It's worth reviewing some of the images for this. It's a pretty, I've never seen it on an ultrasound in real life, and it could easily have faked me out before I read about it for this lecture. Back to some of the benefits of using ultrasound. Here we have a complete aspiration of a small joint. This is actually an MCP joint from the ever helpful POCUS Atlas. You can see you can aspirate almost the entire joint using this. So your yield is going to be significantly higher. You can see that the position of the needle changes slightly as the person is aspirating, which allows you to keep chasing the fluid pocket until the very end. This is an image of someone doing an actual injection. You can see the needle coming in from the right. And this way you know that you're not injecting, because if you're only injecting 1 cc of medication into a space, you could potentially just inject it intramuscularly and not really knowing the exact pressure dynamics of wherever you are. You could easily mistake that for being in the right space when really it's not. So starting with the anatomy of the joints we're going to tap, we're going to start with the shoulder. The shoulder has pretty limited exposure, but thankfully there aren't a lot of delicate structures nearby. Your limits are the humerus laterally, the scapula medially, and just above the scapular spine. And this is the same view that you would use for something like a shoulder dislocation if you're trying to confirm that you've relocated. The humeral head you can see pretty clear. In the middle image, you can see the humeral head pretty clearly on the left and the glenoid on the right. And between those two, in the glenoid fossa is where you're going to get your joint effusion. So when you do your shoulder approach, you're going to go from the top. You don't have a lot of room to work in 3D, so you're not going to be able to do an inline approach. This is what we would call an out-of-line approach, because you're approaching perpendicular to the probe and not parallel to it coming in. So you're not going to be able to see your needle coming in all the way. You're just going to be able to see a cross-section of your needle. So again, you're going to want to make sure that you're not at too much of a parallel angle. You're going to want to angle your needle upwards a little bit compared to your ultrasound probe, which will probably be flat. As far as the elbow anatomy, most of your neurovascular structures are medial and anterior, which is excellent for you, except for the ulnar nerve, which runs a little bit posteriorly. And so the design of, if you think of your ultrasound orthocenteses as designed to avoid hitting some vital structure, this is your vital structure to avoid hitting the elbow, which is why you go so laterally. The elbow you're going to definitely want to do in 2 views. It's a kind of a complicated structure. We don't ultrasound it that often. This is the longitudinal view. You can see the humerus coming from the top. The olecranon fossa is right below where your effusion is going to start to form. And in the transverse view, you can see the condyles, which isn't surprising if you just think about this image from back here. You can see the medial and lateral epicondyle, the ulnar nerve running behind the medial. And your effusion is going to sit right in that happy little pocket. So this is actually the same view that you would use for an elevated posterior fat pad. Remember that your fat pad is elevated by the effusion of the fracture. So in ultrasound, you see the effusion, and on X-ray, you see the fat pad. So you can use this to actually sonographically confirm an elbow fracture. Again, thank you to POCUS Atlas. As far as your elbow approach, you're avoiding the ulnar nerves. You're going to approach laterally. You can do this in the out-of-plane view, but it seems like the in-plane view is a lot easier. Here, you also really benefit from having a pediatric linear probe. As far as wrist anatomy, you're going between the radius and the scaphoid. This is what it's going to look like without an effusion. This is normal wrist. And this is what it looks like with an effusion. These are probably one of the hardest joints to tap out of the ones we're going to talk about today. And so it's really going to help here. You can do both inline and out of line. If you're doing inline, you are almost certainly going to want to have the pediatric linear probe, or just be very good with using only a fourth of the length of the adult linear probe on the person's wrist, or else they're a giant. You can do inline or out of line, but what really helps here is using a small towel to prop the wrist up into a little bit of flexion, perhaps 20 degrees, to get better exposure of the joint. The hip is a pretty big target, but there's a lot to avoid, and it's a pretty long distance for your needle to travel. So this might be the time when you actually get your spinal needle out. You're going to start out with a view that we're all very familiar with, because the last things you'd want to hit here would be any of your femoral neurovascular bundle. If you do your approach right, you should be very far away from this, but you should start out by getting this view that we all should know from doing our bedside DVT studies or doing our central lines. You can see the femoral neck and cross section right there. This is right along the, this is basically right along your iliac crease. If you look here, you're putting the dot of your probe on basically right over the acetabulum. If your view right here is perpendicular to the insertion of the hip into the pelvis, this is parallel. This is you rotating your probe 90 degrees. And you have this thing called the anterior synovial recess, which is right where your femoral neck meets your femoral head. You have a little pouch, and that's where your fluid's going to sit. This is a case of a kid with hip pain and fever. Because hips have cartilage on them, like many joints, this is going to be an important joint to compare to the other side. It's easy to see the small little 2 millimeters of hypoechoic area that form along to the head of the femur, but that's not what you're aiming for. You're aiming for a pocket that's actually round like this. And if someone has a trace effusion bilaterally, you could say perhaps it's physiologic, but if it's unilateral and that's the side that the kid's yelping on, that might point you in the right direction. This approach is pretty similar to for anyone who's done a fascia iliaca block. The approach is lateral, and in this case, you also want to be a little bit distal. Again, you might need the spinal needle. This is going to be inline because you have so much room to work with, but you have a very long distance to cover as well. So you're going to want to do an inline visualization of coming in on this. In this case, you'd be coming in from the right of the image. The knee is probably the first joint we ever tapped. It's special to us, but it also is a place where lots of people with osteoarthritis, people can have bone spurs in the joint, people could have, this would be a place where you could easily have synovial hypertrophy. The main target to avoid here is the quadriceps femoris tendon. It has a lot of force in it. You probably don't want to be stabbing it with a needle and seeing how much more it can take. This is the yellow triangle is where you're going to be looking for your effusion. And this is a really important place to fan back and forth. There's a lot of musculature that comes through here. Thankfully, the vasculature is pretty well protected behind the popliteal fossa. This is a really easy joint to tap using an inline approach. You can certainly use an adult linear probe. You can go either medial or lateral. I've never really seen, I wasn't able to find anything pointing that one leads to better outcomes than the other. Just go wherever the effusion is. The ankle is like the wrist, it's actually pretty hard. You're limited mostly by the patient's ability to actually completely plantar flex their ankle. This is going to, it looks pretty easy for this person who we imagine to be a healthy volunteer. The ankle might be a little bit swollen, but it doesn't look septic by any means. The problem is that for the person who is, or for the person who has an acute gout flare, this might be a pretty painful procedure. What you're looking for here is a longitudinal view of the talus and the tibia, and your effusion is going to, on the left, you have a normal talus and tibia, and on the right, you have a little effusion in the yellow dotted line. The big structure to avoid here is your dorsalis pedis artery. there are ligaments traveling over the ankle joint, so bonus points if you can identify those and avoid those, but would be the most disastrous to hit. In this image, this is either this one is actually not looks like it could be a compressed synovium, but that's actually cartilage. Your approach is going to, because you're trying to avoid the DP, you're going to be coming in laterally, not medially. The orientation of your probe is up to you and based off of whatever you feel like is right for the moment, but your needle's coming in laterally regardless. So in conclusion, there's not really a good reason not to use ultrasound when we have them laying around. Obviously, if all the machines are broken and someone feels pretty confident, then sometimes you have to do what you have to do. But otherwise, especially in cases of doubt, especially if it's something that you haven't done before, especially if it's a smaller joint, and especially if the results are critical, these are all reasons why you would want to use an ultrasound. You know, no one's ever needed, you know, two extra minutes if you have the machine is not going to change much, because this isn't like a crash fem. It's not a urgent procedure. It's not an emergent procedure most of the time. Your linear probe is useful for just about anything. You can't even use it for abdominal and shoulder if you have good enough depth and depending on your use case. Keep that page probe in mind as well, especially if you're trying to do inline approaches of small joints. Your most important anatomy for every single arthrocentesis you do is think about what you don't want to hit, and always visualize in two planes. And there's all those tips for all those joints specifically, but that would just be a restatement of the entire lecture. Thank you very much to Dr. Kilpatrick, Dr. Hannison, and Dr. Marrero for all the excellent feedback. And thank you for Dr. Yu and Dr. Warshaw for letting me practice on you guys. If you have any questions, please fire away. I'll pull open the chat. Otherwise, here are my many sources. And I can provide this to anyone who's interested in any of those bits. Any questions, Em? Yeah, just a couple of compliments.
I was just going to say, I mean, I totally agree. I think if you have an ultrasound, there's no reason not to use it. I would say probably for education, learn about the landmark ways of doing it too. And then I'd say this for central lines too. Go use the landmark and say, okay, I would probably go right here and try to do it with the pieces. And then get your ultrasounds to confirm that. And I think it's just good practice as a resident to do that. I agree. It's not a situation where it needs to be done emergently and very timely. You have to rush to do it. So why not get it done?
I agree. I'd like to be able to know how to do every procedure blind, but that doesn't mean it's the right thing for the patient. And if I'm going to learn how to use it blind, it could be nice to have some training wheels on first. But this lecture is, you know, that's for the advanced practitioner.
I think especially because of how we usually do procedures, it's pretty good to know that it's not on guidance through the simple. I've done an ankle in a year, shoulders a couple of the last few weeks, but you know, not something we do with high enough volume.
Right.
Really, from the attending perspective, and I'm guessing from the residents as well, gaining that confidence from experience. Definitely, if I was a trainer, definitely what Wilson mentioned is perfect. This is what I would do. Are you right? Right. Make yourself better. Train yourself so that you have the best success rate.
Yeah. We also don't have that much IV drug use. I know that's not every cause of every single effusion, but I can imagine, other than rheumatologic causes, as far as like getting, like didn't get to do the taps, but as far as I've seen both a wrist and an elbow from IV drug use, that could be a case where it's really important because you want to get cultures before you start antibiotics. And even if that person isn't going to die, they're losing cartilage. But I agree with everything you said. Dr. Granchon?
Yeah, I think, except for the knee, I find the knee is so easy to do anatomically if you were tapping it for an effusion. But for the other joints, which don't get much of an effusion, I think the ultrasound is really a good thing to have.
Absolutely. Donald just Don Dukas chips in. His last two taps have gotten stuck on membrane and he had to do quick injections of lidocaine to burst through. I know injecting into joints is controversial, but I guess it depends on your case.
And just I don't think it's that controversial, as long as you make sure.
That it's sterile, right?
infected. I
Right.
think it works well. The other thing is that if you're injecting it, a lot of people like to put a lot of lidocaine there. I don't, because, if I'm injecting, the soft tissue and tendons and those things, yeah, then I use lidocaine with the steroid. But if I'm just
Mhm.
going into a joint, I just use the steroid, because if you numb the joint too much, they may hurt it at the beginning. So I don't
Oh, I
put
didn't think about that.
lidocaine inside the joint. I know people do, but I don't. What about you, Rich? You've done a lot of joints
Oh, I used to like.
in the joint
Because they
itself.
feel better right away.
Yeah, you do.
All those are the lidocaine cartilage optics of them.
Interesting. And I also heard that I find the place to confirm it that that giving with epi can be bad for cartilage. It's bad for the small vasculature in it. So never use epi. There's no reason if you're bleeding from doing an arthrocentesis, something's gone horribly wrong. Thank you.